Good afternoon. Thank you very much for giving me the opportunity to speak to you today about a newly approved medication, satralizumab, for patients with NMOSD. As you know, that we have witnessed over the past several years a change in paradigm in managing and treating patients with NMOSD. In the past, we used to rely on use of immunosuppressant agents, which are, as you know, are not approved medications for patients with NMOSD. However, for the past several years, we have seen and witnessed some change in the way we treat this condition with the use of targeted therapy, either targeting B-cell therapies or targeting the complement, or very recently, targeting interleukin-6. And the question you may ask, why interleukin-6? Well, we all know that in patients with NMOSD, we have seen that interleukin-6 is elevated in the CSF of patients with NMOSD, and more importantly, there's a correlation of the level of increase of interleukin-6 and the extent of injury at the level of the spinal cord. In addition to that, we know that interleukin-6 is heavily involved in the pathogenesis of NMOSD. Whether we are talking about the involvement of interleukin-6 at the level of the periphery or at the central level. At the periphery, we know that interleukin-6 promotes plasmablast survival, and it does enhance the IgG, aquaporin IgG production. We also know that interleukin-6 promotes differentiation of pro-inflammatory cells, including Th17 cells, and that would obviously lead to T-cell mediated inflammation. We also know that interleukin-6 increases the blood-brain barrier permeability, and that obviously would enhance the penetration of aquaporin for IgG and inflammatory cells and their entrance into the CNS, and at the level of the central nervous system, they are involved in the astrocytic injury, because we know that aquaporin IgG binds to astrocytes and leads to interleukin-6 production, and that astrocytic interleukin contributes to the inflammation and obviously cellular injury. As you all know, that NMOSD is characterized by repetitive attacks. The problem with these attacks that most often that with each and every attack, there is a residual deficit. And as you can see from this slide, there's always some residual deficit after each and every attack. So by the time patients would have more than 6 attacks, their level of ADA score could be as high as close to 6 with the repetitive number of attacks. In addition to that, we know that by 7 to 8 years of the disease onset, about 2/3 of patients with NMOSD would exhibit severely enough disease accumulation that would impair their ambulation, as well as could lead to blindness in at least one of their eyes, again, 7 to 8 years out from the disease onset. The newly approved medication, satralizumab, or its trade name Enspryng, is the first and only approved home treatment for patients with NMOSD that we have currently available on the market. Its efficacy had been approved and well presented in at least 2 pivotal trials, which we will discuss later on, the combination trial with immunosuppressive agents, as well as by itself as monotherapy. It is well tolerated we have more than 2 years experience with the medication, and there's clearly no evidence of increased infection rate as compared to the placebo arm. It is the first and only sub-Q treatment that is currently available for patients with NMOSD, and obviously that has the advantage of being administered at home, or if patients prefer in the clinic. It has a very unique and novel mechanism of action that had been developed specifically targeting interleukin-6, and we have already listened to the role of interleukin-6 in the pathogenesis of patients with NMOSD. Now we know that Enspryng has a novel mechanism of action that has been specifically developed in patients with NMOSD. We know it targets the interleukin-6 autoimmune activation and obviously the CNS injury. It has the recycling properties, and that is very important because we know that with this medication, it is recycled back into the bloodstream, and that would obviously allow it to bind to more antigens, and that would lead to prolongation of its half-life, and that would explain why this medication can be administered by injection once every 4 weeks. The initial and the first pivotal trials that had looked at the efficacy of this medication was the Sakura STAR, which again is that has shown the efficacy of this medication in combination with immunosuppressive agents. So the inclusion criteria for that trial, they included patients with a diagnosis of NMO or NMOSD. They included both adults as well as adolescents who are either aquaporin IgG positive in about 2/3 of the cases, or they may also include patients with aquaporin negative. Patients had more than one relapse in the last 1 year or more than 2 relapses in the last 2 years. And the patients were randomized 1-to-1 to either the arm where patients were randomized to medication, Enspryng or satralizumab, plus immunosuppressive agents, or the arm of immunosuppressive agent plus placebo. And at the end of the double-blinded period, which is about 107 weeks, patients will, after that, will enter the open-label extension phase of the trial. The primary endpoint of the trial was time to first relapse. There were also some secondary outcomes of the trial, but the main primary outcome of the trial was time to first relapse. If you look at the demographics of the cohorts of patients that were enrolled in that trial, they included patients, as I mentioned earlier, who are aquaporin IgG positive in about 2/3 of the cases. Their mean age, they were in the 40s. They included adolescents in about less than 10%. And most of their cases were female in about 90% plus. If you look at the average annualized relapsing rate in the previous 2 years, they were on average about 1.5. Their average ADS score was about 3.6. Half of their cohorts, they were using prednisolone or oral corticosteroids, and about 1/3 they were using azathioprine, and about 10 to 20% they're using mycophenolate as immunosuppressive agents. Now, if you look at the result of the trial, satralizumab or Enspryng combined with immunosuppressive agent reduced the risk of relapse by about 80% in aquaporin IgG positive patients as compared to the placebo. If you look at week 48, the relapse-free rate was around 91.5%, and at week 96, the relapse-free rate was about 91.5%. So the clear reduction in the relapse rate by almost 79% in the aquaporin for IgG positive patients. So we can say that the combination with immunosuppressive agents in 9 out of 10 of patients who are randomized to the treatment arm as compared to 5 out of 10 with patients who are randomized to placebo arm, patients had remained relapse-free up to 2 years of the treatment. So that was the story with Sakura STAR. And if you look at the adverse effects or the tolerability of this medication, the medication was well tolerated, with the mostly reported side effects in more than 5% of the cases were basically arthralgias or injection side reactions. But most often the drug was well tolerated. There's no evidence or signal of a serious infection in patients who were randomized to the treatment arm. Now, what about Sakura Sky, which is another pivotal trial that looked at the efficacy of this medication as monotherapy? With Sakura Sky, similar to what we have seen with the inclusion criteria with the previous trial, they included adolescent as well as adults who are aquaporin IgG positive in about 70% of the cases with a diagnosis of NMO or NMOSD who had more than one attack in the past 1 year. Patients were randomized 2-to-1 to either the medication Enspryng or to the placebo arm. And after 96 weeks of the end of the double-blinded phase of the trial, patients would enter into the open label extension phase of the trial. The demographics, about 70% of the patients had aquaporin IgG positive, mean age about 40, about 90% were females, and if you look at the average annualized relapsing rate was about 1.5. The average EDSS score was about 3.6, similar to what we have seen with the previous trial as well, where the average score of EDSS score was similar to what we have seen with this Sakura Sky trial. Now, if you look at the results of that trial, again, Enspryng or satralizumab had reduced the risk of relapse by 74% in the aquaporin IgG positive patients as compared to the placebo, where the relapse-free rate at week 48 was reduced by 82% and to about 76.5% at week 96. So in summary, 8 out of 10 patients, as compared to 4 out of 10 patients in the placebo arm, would remain relapse-free at 2 years. So that is a very significant result in favor of the treatment arm as a result of this trial. If you look at again, the adverse effects, similar to what we have seen with the previous trial, the drug was well tolerated, with the mostly reported side effects were injection site reactions, arthralgias, but otherwise the drug was well tolerated. There's no evidence or any signal of serious infection or opportunistic infection in patients who were started on or randomized to the treatment arm. Again, there is no evidence to suggest serious infection as compared to the placebo, including meningococcal or opportunistic infection. There's no anaphylactic reactions or deaths that had been reported with this medication. None of the patients had discontinued the trial due to injection site reaction, and there was no specific vaccination, obviously beyond routine or pre-treatment required prior to initiation of treatment with this medication. Now, how is the drug administered? Well, obviously it will follow a loading phase where patients will receive the first injection at time 0, then 2 weeks later they'll receive their second injection, and 2 weeks later they will receive their third injection. So they will receive 3 injections in the first month, and then thereafter they will receive 1 injection every 4 weeks. It obviously has the advantage of being administered at home, or if patients prefer to, obviously, they can receive it in the clinic, but it can be used as monotherapy or as in combination with any other immunosuppressive agent. So overall, the drug has shown good evidence of its efficacy, as had been shown in the 2 main pivotal trials, either as monotherapy or in combination with immunosuppressive agents. It clearly was superior to placebo in terms of reducing the risk of further relapses. The drug was quite safe, and there's no signal of opportunistic infection or serious infection in patients who were randomized to taking this medication. And this safety profile had been shown up to 2 years of the study period. There's no evidence of anaphylactic reactions or deaths in patients who are started on this treatment. The medication can be used as monotherapy or in combination with immunosuppressive agents for both adults as well as adolescent patients from their first attack onwards. Obviously, it has the advantage of being administered either at home or in some cases at the clinic if patients would prefer to. So if you summarize the 2 initial pivotal trials on this medication, clearly the combination with immunosuppressive agents, as a result of that trial, 9 out of 10 patients who are randomized to treatment arm as compared to 5 out of 10 of patients who are randomized to the placebo would remain relapse-free at 2 years out. Whereas in the case of monotherapy arm of the trial, 8 out of 10 patients who are randomized to treatment as compared to 4 out of 10 in patients who are randomized to treatment to the placebo arm would remain relapse-free for up to 2 years of the trial. So clearly, based on what we have seen so far, the advantage of this new molecule of treatment and the new targeted therapy for a patient with NMOSD, we clearly have proven that we can now do now what patients would need next. Thank you very much for your attention.